Hi, everyone. Welcome to ACR 2025. This is the day one recap where me and my friends here who've been in Chicago, are going to talk about the things that we saw today that we thought were worth bringing to your attention as what you may have missed. We're going to begin with introductions. I'm Jack Cush from Dallas, Texas. Orly
Hi, I'm Aurélie Nage from Glasgow, Scotland.
and Yus.
Hello, my name is Yusuf. I'm from Leeds, but I'm reporting live in Chicago.
Leeds, a lot of things going on in Leeds these days we'll talk about maybe here. We're going to be joined in a few minutes by Dr. Janet Pope. She, like the rest of us, were scurrying back from the convention center to get on this call. So in this day one recap, we're each going to share our thoughts and impressions on impactful research, things with clinical impact, things that are certainly worthy of some discussion. So why don't we begin with Dr. Yusuf?
Yeah, thanks, Jack. The one thing that I want to cover today is pertaining to the update of the American College of Rheumatology guidelines of a non-renal SLE. As you may be aware, the previous guideline was back in 1999. So there was definitely an urgent need to update, all these guidelines, particularly with all the new licensed therapies in lupus. So essentially, this was presented in a session today. So it's really good because initially it presented how the guideline was developed, and after that, what were the key recommendation, and followed on after that, they actually make some practical sessions. So, for example, they broke down, for example, if you have refractory cutaneous manifestation, how do you do? Then we'll apply the guideline to clinical practice, and then to pleural pericarditis and so forth. So just in terms of the guideline themselves, there were 65 recommendation, but only three really the one that with strongly recommendation means like with the highest quality of evidence. So the three key messages from this non-renal SLE guidelines were one, hydroxychloroquine for everyone unless contraindicated. Secondly, if you're using glucocorticoid, make sure you taper them and also to the lowest possible and at least less than 5 milligram per day. And also the third one, the strong recommendation one, was to escalate therapy if the initial therapy fails. So these are the three main things that were strongly recommended. And then after that, in the flowchart diagram for recommendation, you got all these disease features management, but most of them were conditional management. And you can see like from using immunosuppressive therapy and also biological therapy. So I think this will be really useful, for people to then start applying this, and also maybe people can also do some audits after that to see whether it'll be adopted in the practice.
Certainly, they're always needed and desired. It's a little distressing that they still have so many conditional recommendations coming from the experts like yourself. But nonetheless, without good evidence, they can only be conditional, can they not? I'm surprised that there isn't a recommendation in there about hydroxychloroquine monitoring. Is that in there, or was that discussed?
Yeah, so I think it didn't mention about monitoring. So it mentioned about the starting dose, where you can ideally you'll be within 5 milligram per kilogram, but you can actually start higher dose temporarily before you bring it down in patients who are resistant, with really severe disease. But yeah, I couldn't see any monitoring there. So perhaps like we need to dwell into it, when the full manuscript will be published in a few months. Yeah. Mhm.
Yeah, I think there's another presentation at this meeting again on hydroxychloroquine monitoring. It seems to be the standard by the leading centers, and I would strongly advocate for it. Orly, you have any ideas or suggestions here?
Yeah, I was wondering is Did they follow the whole systematic literature review process? Was there any specific challenges considering that it's almost like in lupus, it feels like there is like very old evidence and then like a whole bunch of very new evidence and kind of nothing in between. So how is that addressed?
Yeah, so I think that's a good point. So I think this is what Jack was mentioning just now, because it's slightly bit disappointed out of 65, there were only three like was strong recommendation. It was because of we have a separate guideline for the lupus nephritis, which was recently published. So in there, so you had more strong recommendation because you had more clinical trial, very high quality evidence trial on that one, but not so much in the non-renal because it tends to be with non-renal, they lump it all non-renal. So it's quite difficult to do like a, subset analysis. But even if you do like a subgroup analysis, it's still not powered to answer all this. So hopefully maybe in the next guideline, because currently they are planning quite a few trials that doing a target specific, organ specific trials. For example, that there are phase 3 trials in cutaneous lupus on its own. So, perhaps after this, people will do, lupus arthritis trials and so forth. And hopefully we'll get more, evidence, based on more disease specific. Yeah. Mhm.
So it's driven really by the trials, and the trials are driven by drug development. So we have lots of new lupus drugs all seeking a lupus nephritis indication, as opposed to a general lupus indication, which is actually harder to achieve. I think that now there's sort of a pathway forward to do CLE, chronic lupus skin disease, clinical trials with a classy endpoint that maybe we'll get some clarity there. But I mean, we want these guidelines to help us in other areas, hematologic lupus, CNS lupus, articular lupus, et cetera. So it'll be good to review these, and if anything, it draws a line in the sand on future research. And as you say, if we do an audit, the audit will tell us how good are we at doing at least what the experts suggest that we might do. Fortunately, we're joined by Dr. Janet Pope. Janet, introduce yourself to everyone.
Hi, Janet Pope, rheumatologist, Western Uni in London, Ontario.
Excellent. All right, so we just heard from Hughes. His favorite starting abstract was the new ACR guidelines on non-renal lupus. Orly, you're next.
Yeah, so I wanted to talk about this presentation I saw at the plenary session, 775. There was quite a whole bunch of presentations about, at-risk patients and who's going to develop clinical RA and can we predict, and it's almost like we could take all of these talks together and make a prediction model or a score, to test. But this one in particular, why I looked into it further. So it's the bacterial RNA, so the TDR1. So basically, they took plasma from patients from the studies of etiology of rheumatoid arthritis. So it's an old cohort, and some of these patients were at risk for rheumatoid with high CCP titers, and none of them had clinical synovitis. However, it was not clear, and even looking back in the literature in some of the early publications of this cohort, whether they had had any form of imaging to look for synovitis, and that might be a caveat of the study, but we can talk about that a bit later. But ultimately, what they did is this microbial RNA they're particularly interested in because they demonstrated that in people with RA already, they had a better response to the biologics, and they had a less severe kind of phenotype if they had high levels of this specific RNA, which is considered to be regulating genes expression, like epigenetically. And so they looked at 60 patients at risk. And they compared to like over a double amount of patients seronegative. And first of all, one of the things that I noticed is almost half of the patients converted, which is not our typical ratio of patients that convert. And so that's why I think that might be another caveat here. But ultimately, what they showed is that after adjusting for smoking and a whole bunch of autoantibodies, the presence of this RNA was massively associated with a lesser risk of converting into clinical RA. And they presented this area under the curve, which was like 0.86, which was actually higher on its own than a model that had associated rheumatoid factors, smoking status, and HLA, they are like shared epitope status. And then when we're combining all together, it was 0.9. So it was very close basically on its own then with all the clinical parameters. And that is something that I found quite impressive because usually, it adds a little bit maybe to the strength of the prediction, but a biomarker that on its own has such a strong prediction was pretty impressive to me. Now, obviously, there's a bit of caveats to that. So, as I said, they had a very high percentage of converters, maybe because some of them already had, subclinical synovitis. Maybe it wasn't checked. And also, it's not been validated in any other cohort. And we know very well that sometimes we have these amazing biomarkers, and then you test them in a different cohort and it doesn't do as well. But if this on its own is able to be such a strong prediction factor, because it's not hard to look for it in the blood, it could be quite promising if it's validated. We don't know how though. They did some in vitro stuff looking at transfecting this RNA into cells, and it does seem to affect interferon pathway, but it's also a bacterial kind of RNA anyways. So maybe because interferon is associated with response to germs, and it could well be that. So difficult to say how, but if it does get validated, then I think it's exciting.
Yeah, this one caught me by surprise. It wasn't on my list of things I wanted to see, but a lot of the correlations here were interesting. Again, these are sRNAs that are, appear, and she made a point of these being probably of bacterial or, origin, but they don't have to be, and they can be endogenous as well, but they have a regulatory function. They impair, protein synthesis, and certainly get in the way of alpha interferon signaling, which they say seems to be an early event in RA and maybe RA progressing, or, clinically suspect arthralgia progressing. So they tied up a nice little loop on this, and now turned this into, most sRNA kind of research kind of goes nowhere, in the past. I think that this is looks very interesting, and I think there's a lot to be learned still. Anybody else have a thought on this?
I think you're
All
on
right.
mute.
Sorry.
Yeah.
Yusuf, what did you say? What did you say, Yusuf?
I think Janet was on mute, sir.
Oh, I was just going to say, all I would say is we always have to beware. It's hypothesis, I think, generating and not testing. A lot of different analyses were done. However, it's kind of quite interesting.
Yeah, absolutely. And that's why I think I'm glad it was a plenary session, because I think this, if this was a poster, it may have gotten buried, and hopefully this will spur more research in this area. Dr. Pope, what do you have for us?
Right. So, Jack, I picked something that you really like. I looked at adult onset Still's disease. So this was a poster. And again, there's lots of little pearls in the posters for sure. So it's 0163. And it was by a third-year internal medicine trainee, a room keener. So Dr. Mohammed Akram et al. So what was it? It was looking at trends in hospitalization with outcomes and adult onset Still's disease from the United States from 2016 to 2022. So you would say, why on earth would I pick that? Like Stills is pretty rare and everything, but here's why. This is a giant database of multiple hospital records throughout the country. It's Medicaid, Medicare, a whole bunch of stuff, national database kind of stuff. So there were hospitalizations really so many, the N is so big. It was 1827 unweighted and 9,135 weighted hospitalizations in the US for adult onset Still's disease. So some of these I would speculate were first diagnosis and some were recurrence or who knows what. So the first thing is, who is more apt to do poorly in hospital? Men more than women, ethnicity identified as Black versus others, and those on Medicaid because they're possibly older. So not all of that kind of makes sense to me, but here's where I found it really interesting. So the most common reason they said for hospitalization in adult onset Still's disease was infection. So I asked him like how many were culture positive, because of course Still's is high temperature, rash, high ferritin, high CRP. How do you know it's not Still's? And the answer was, who knows? This is what they were coded as infection. So the good news is only about 2.4% mortality. The bad news is I'm not sure, well, not bad news. The equivocal news is I'm not sure that these patients were, no, I'm not sure that these patients actually had infection, or was it infection and Still's, because it's really hard to differentiate, and they couldn't get as granular as you would like to see if they, you know, how many were culture positive, or lots probably got antibiotics, and if the fever didn't settle, they probably got glucocorticoids. But as I say, the reason I was interested in it is this is the largest amount of data on adult onset Still's I've ever seen. And I guess I can ask each of you, like, how many Still's patients are in your practices? Jack, you had an interest in it when you were doing a heavy practice. What number would it be?
Oh, I always carried about 30 plus, 30 to 40.
Yeah, and that's a lot. Yeah.
Yeah, but I see people from all over the country and sometimes outside of the country. I probably in my career have seen over 500 Still's consults. I think I've only seen about somewhere between 30 and 40% of the consults actually had Still's, for the reasons that are apparent in this report, that they get cold Still's because they don't know what it is. It gets admitted as infection, and certainly infection, everything from, you know, tularemia to Lyme disease could actually look like Still's. But you know, I don't know that you're going to get this from hospital ICD-9 codes and whatnot, but it still is interesting. And if only to look at the absolute number and then also the mortality rate. I mean, I always teach that nobody should die from Still's. If they die from Still's, they're going to die from MAS,
Yes.
or they're going to die from steroids. So you gave them too much steroids,
Right.
you got into steroid complications,
Immune suppression.
infections. Right.
Yep.
So,
Yep.
but
Yeah.
you shouldn't die from Still's. So,
Right.
But
yeah. And I mean, because you have had expertise in this, I probably only have less than 10 true adult onset Still's. I have some kids that mostly grow out of it where we follow them as adults. Or Lee and use, about how many Still's patients would you have?
Yeah, so I think it's very rare. So I probably see about once every 6 months, if that.
And I wouldn't even see a new one every
New
6.
case. And I know
Mhm.
one of my colleague called Professor Sinisha Savage. He does the auto-inflammatory clinic. So I think he picked up a lot more of
Yes.
cases.
Yeah.
But I don't think that his cohort is as
Yeah.
big as is reported here as well.
Yeah. And Orly, pretty rare
Yeah.
for you?
Oh yeah, definitely.
Yes.
Definitely.
Yeah.
Yeah.
So,
Yes.
right.
That sounds
So
quite huge to me. Yeah. This
exactly.
number. Yeah.
So I wondered about misclassification, but I think the teaching point for the people listening is certainly you want to see the fever be monophasic every day, and that it peaks and goes back to normal. Whereas a septic patient, they don't usually go back to normal and they can peak more than once a day. And that often the rash comes around the time of fever, but you don't have to have a classic rash, and it can be macular papular. It can be that salmon non-raised. If it's bad enough, it just looks like a macular papular. And that, you know, we would tend to try to avoid steroids once we can get them on an IL-1 or an IL-6 or something. But that's why I picked it. It was a large N, and I don't know the amount of misclassification, but I don't think people just rush to saying Still's unless someone's confirming it on a consult, because we get consults every week. Is it Still's because their CRP is high? And we go, it's infection, or cancer. Probably not Still's.
right. All right, that was interesting. I want to talk about abstract. I want to pay honor and homage to the University of Leeds. An abstract 832 from the lead author was Sharrock, I think was the name. And this was about predicting those, Santa Sharrock at Leeds, predicting those who will progress from clinically suspect arthralgia to RA. So this is banking on the well-known voluminous experience in early arthritis at the Leeds Center. And in this particular study, they looked at the factors that may influence those who might progress. So they looked specifically at PADI 2 and 4, the enzyme that is involved in citronization. So both PADI 2 and PADI 4, very important here. They had sort of data before, and they followed people, and they looked at levels in 79 CCP positive at-risk individuals who did not yet have inflammatory arthritis, 34 with early CCP positive RA, and 44 healthy controls. And then, they looked at the clinical parameters, obviously a difference between RA patients or as far as, and the controls, controls not having any serologies. The RA and the at-risk had serologies by definition to get in. And they looked at PADI 2 and PADI 4 levels. And so while both PADI 2 and PADI 4 were elevated in RA, the only one that seemed to be really interesting here was PADI 4 in the at-risk individual. So you could find PADI 4 and PADI 2 in early RA, but the patients who were CCP at risk had a lot of people who had high PADI 4 levels. Now they're just measuring PADI 4. There are a lot of studies out there about antibodies against peptidyl, arginine, deaminase, and that being associated with ARA risk and worse disease or progression. But here they're actually just measuring PADI 4. So the idea is that there's more PADI 4 and there's more PADI 2. I asked the question, what's the mechanism here? Is it driving more citronization? Are you having higher and more CCP levels? And we do know more CCP and multiple autoantibodies increases risk as well. She didn't quite answer my question because they said they had to have CCP to get in the study over 100, as if to say that that's a lot. I don't know that 100 CCP is the same as what we usually get, which is CCP greater than 250. You sort of you get 3 reports on CCP, and now I'm really getting into a tangent here, but you either get a negative CCP or a very, very high CCP, and then some other number that's like 30 to 100. Who are those people? And are they at risk to progress or have worse disease? And no one really knows much about them. Anyway, in this study, they all had CCP. She wasn't able to answer that. Again, if you did have PADI 2 and PADI 4 in high levels, you were more likely to, and higher than, they had a high PADI 4 versus low PADI 4, high PADI 2 versus low. The high levels were people who were going to progress to RA more quickly. So the point is, unlike some other studies that we've seen here today, PADI 4 has predictive ability and augments the number of people who will progress from clinically suspect arthralgia to actual inflammatory arthritis, where we know if you just have arthralgia and you're CCP positive, you have a 1/3 risk. And when it's more than that, you wonder about the data set and whatever. But here it clearly augments the number. So I think this is why it was an oral presentation. It was well done. I think it's important work. Okay. Why don't we go on and do one more round? You have a quick one that you want to point out to the audience?
Yeah, so just the quick one from plenary again. So this abstract number 776. So this is actually data from 2 year study of Select GCA. So as you know, that April this year, both the FDA and EMA have approved the use of upadacitinib for remission induction of giant cell arthritis. So in this trial, so they just take on a little bit more further. So what happened after the 52 weeks trial? So I think it's about 80% people are eligible, for this, extension studies. So what they've done was whoever's in the placebo still remain in the placebo for another 52 weeks. For people who are on upadacitinib, either 7.5 milligram or 15 milligram, which is the dose that was licensed, then been re-randomized, whether they will then switch to placebo or they will maintain the drug. So what they found at so the following 52 weeks, so it's like 2 years altogether, they found that those who continued the upadacitinib, so they had a higher remission rate as their definition, so 69%, compared to only 29% for those who were initially on upadacitinib 15 milligram who switched to placebo. So this is really interesting to say, initially we all thought like, when similar as tocilizumab as well trial. So when they first initially did the 52 weeks, then people asking, whether is it safe to stop and then see how it goes. But I think in this case, we were asking the same question again. So, you had an initial remission induction, whether can we stop after 1 year or should we continue? But so this data, may suggest that, we need to continue. And in terms of safety perspective, although this is like aging population where you are concerned about the use of JAK, so they found that the risk of serious infection is actually lower in the upadacitinib continuous for 2 years, likely because of the steroid, becoming really less. But also there's some, as you expected, increased risk of herpes zoster and also some slight raised CK. And there was one VTE occurred in the upadacitinib continuous group for 2 years. So I think it's really interesting, like, but the study is added more value that, I think we probably need to continue upadacitinib after 1 year. But then again, how long? So probably the story will continue, for the extension studies probably. Yeah.
Yeah. So did they field the question about since this is only a 2 year study, they couldn't really say much more about what to do. But did anybody bring up the issue? How long do you treat GCA?
Yeah. No one actually brought the question up actually. No. Yeah.
So you wonder, I mean, the whole issue here is to justify the ongoing use of a new JAK inhibitor. You got to show this kind of data. You've got to show the safety of it. I guess relapse rates would be the other primary outcome. At some point, they're going to have to get into a cost effectiveness analysis. And you can avoid that kind of analysis if you start looking at things like death and hospitalization as outcomes. But I guess with these kind of therapies, these people shouldn't die and shouldn't end up in the hospital. So I don't know what else they can do. The interesting thing about these, the development of drugs for GCA and for that matter PMR, I think it's great, but we still use tons of steroids. We still aren't using much IL-6 inhibition. We're not rushing to, I don't know what the numbers are on the use of UPA or JAKs in GCA right now, but we have IL-17 drugs that are looking good to some extent, and there are others in the wings. They're all expensive, and you're going to have to justify their use. Janet, what would you recommend to these people who are going to develop these drugs?
Right. So just a couple things, I guess, to kind of clarify is that the first thing is, interestingly, secukinumab negative in GCA, phase 2 positive, phase 3 neg, but just had a positive study in PMR. So that makes it complicated. Sirolimus is PMR, and then we've got tocilizumab and GCA, and now, eventually soon to come, I hope, for all of us, the ability to prescribe regular dose upadacitinib in GCA. So with that being said and done, I think we have to learn from these protocols that if we use a steroid-sparing drug, I'll be a bit provocative. I'll say the majority of patients. The majority might not be the majority in my practice or your practice. It might be the majority in someone else's. But in these patients, then you have to do this rapid steroid tapering, or how much bang for the buck are we getting? And what was really interesting in the second year of GCA with UPA, you stop drugs, they stop working. We already learned that with tocilizumab, that this is a chronic disease, at least for a while. You need more than 1 year of treatment. But that overall, you were saving at least on average, not everyone, a few grams of glucocorticoids if you got UPA year 1 and year 2 than if you didn't get it. So you can 3,000 milligrams. It's a median. I mean, the mean is a bit different, but that's a lot of steroid sparing. So I think we have to be bold and do rapid tapers if we're going to use these advanced therapies. Or I would say, as the payer, then you tell me what the outcome and benefit is, because increased hospitalizations occur from their glucocorticoids. So there were less hospitalizations in some databases observationally if you're using an advanced therapy, which in the observational data so far have been with tocilizumab. So we need more than a year of treatment, and we need to get those steroids down quickly. But it gives me the ability to say, I think I want to do that, and I don't know where to put an IL-17 in until we have even more data.
Yeah.
For GCA.
So orally and use, are you using these newer either tocilizumab or any other therapies right now to steroid spare in GCA?
So in the UK, we can only use tocilizumab. That's the only one that currently, but even then, in the initial approval for a year. So, for continuation beyond that, it has to be discussed in the, multidisciplinary team, to approve that for patient with severe refractory and also high dose steroid. And yeah.
I think it's not a bad idea that you should have to defend your decision when the decision is an expensive one.
But also, now we have the tocilizumab biosimilar, so that probably will change thing for regulatory as well. Yeah.
Absolutely. All right, Orly, what's your quick hit?
Yeah, well, in the topic of glucocorticoids toxicity, 0792, that was quite interesting because it looks specifically at skin toxicity in people receiving glucocorticoids. And, I always have patients coming in and say, oh, since I've started, I'm bruising and this and that. But I hadn't really seen a lot of work looking specifically at that. So they had this cohort of patients. It's a cohort that is prospectively enrolling people that are taking glucocorticoids. And first thing, disclaimer, these people were on average 30 milligrams. So it's not really the typical, rheumatoid population, clearly, but it's more so people with myositis and so on. But the thing that I found quite interesting, in their 90 patients that they followed up, they wanted to assess baseline and month 6 and what factors were predictive of skin toxicity. So obviously those people that were older and, that had higher dose and more severe disease and higher disease activity were more likely to develop skin. But the thing that I found really interesting is that there was a really strong association between people who develop skin toxicity and neuropsychiatric toxicity. It was basically very similar, and the muscular toxicity as well. And I think one thing that I certainly haven't really done in my practice is, if there's skin toxicity, let me look specifically for neuropsychiatric toxicity, or let me look specifically for muscle toxicity. But apparently they come together a lot, and so the main message in a nutshell is, if there is skin toxicity, look for all the toxicities as well.
Sage advice. I like that. Janet, you got a final one?
Yeah, and just on that point, Orly, I wouldn't have thought it either. So it might just be a cumulative dose effect. If
Yeah.
you're already having one organ, think of others. So I love that. So I just have a really quick one. So it's kind of because patients ask me this stuff. This is poster 0164, and it was saying, do patients with rheumatic diseases flare with extreme weather? So first of all, patients don't ask about extreme weather. There's lots of data so far from basically Vienna and in US and elsewhere that seem to suggest that a subset of patients, because we'll get to extreme weather in a second, but in regular weather changes, that a subset of patients reports at least self-reported flaring when under two conditions: when the barometric pressure has big changes, so it gets damp, and or when the temperature gets a big change, mostly for the colder. So big delta temperature, big delta barometric pressure, and not everyone, but maybe up to a third of patients flare. And in my opinion, and I think what some of these other studies have shown, is that this flare is fairly self-limited. It might be subjective because they don't come in all the time for that. And it could be multifactorial. People don't feel as good if it's sort of damp, rainy weather, etc. This question, though, this was a large survey, about 180 people, I think, were surveyed, and the response rate for a survey like this was pretty good. It was over 55%. But it was a survey on what happens to you during extreme weather. So we're talking like hurricanes, your power being out, in Canada, snowstorms, but this is a California study, so it wouldn't be snowstorms there, but basically extreme weather. And so what was kind of interesting is that at least the people that completed the questionnaire said, yeah, they do flare, but they're flaring even 90 days after. So I talked to the presenter, seemed very knowledgeable about this. The first author was there presenting the poster. And I said, but do you think maybe it's biphasic, that maybe the shock and this big extreme weather change, like a hurricane or a tidal wave or something comes through, that maybe your joints do hurt more? But if you're going 90 days out, I think that's the stress of losing your house or losing your refrigeration or someone being injured or just the cost of all this stuff being uprooted. So I said, I'm not sure. I said, I think you might have to do a control group of maybe not extreme weather, or maybe a control group where, they don't have our inflammatory arthritis and what happens with extreme weather, because I think my quality of life would go way down. However, I think the bottom line is it's an interesting area, and I don't know it's the extreme weather. It might be the repercussion of the extreme weather that's going to make you for 90 days, all that stress involved, still have a lot of rheumatic complications. And I don't think they asked beyond that. So there you go. It was an interesting study. No take-home message yet, but I think more work needs to be done if we want to really, answer this question a little bit more.
Okay. Obviously, always a lot of talk about weather and arthritis, and always never enough good information to know. When I look at studies like that, I always think of a study that I looked at during my fellowship that was published in 1957. I think it was 500 RA patients who had daily exams for a week. And it looked at what happened to the RA exam in 7 days. And there was 20% variation, and you would think that doesn't make much sense, but it just shows you, and they were done by the same examiner, and the same patient. So if you're doing a study on weather, my goodness, the story in Texas is you don't like the weather. Wait a minute, it changes overnight. I'm sure it's that way where all we live. So these are really hard studies, but I think it's good to support the patient and tell them it's definitely the weather. You should go on vacation, or just get them through it, because you can't do anything about it, and moving to Arizona is not going to help. That's been proven to be useless. So anyway, my just quick one is that there were a lot. I was interested in. I mean, there was a lot going on today. We had the year in review, which I heard was great. We had thieves markets. We had the year in review for pediatrics. And obviously we had the plenaries, which were really interesting. I saw a lot of papers or presentations today about this early RA progression to RA thing, conversion to RA. And I think the funniest part of it all was I think I saw no less than 8 different cartoon models as to what happens when you go from, you know, the influence of the genetics and environment leading to symptoms, but not arthritis, all kinds of cartoons like that. I thought that was really interesting. So I covered a number of those, and that was my first report. The second one has to do really the a basic science exercise coming out of Stop RA and Kevin Dean's group. They basically looked at 2/3 of their patients, a 144 patient trial of people who were seropositive arthralgia, and could you prevent progression to RA by giving hydroxychloroquine versus placebo? As you know, the trial failed. But they looked at about 100 of those 144 patients to see if a multi-omic approach, cellular subset analyses, transcriptomic analyses, single cell seq analyses, could give you some insights as to who's going to progress. What they didn't find out from all those studies was who's going to respond to hydroxychloroquine was what we really want to know, and that didn't happen. But they did, with some degree of certainty, show us that if, yes, it's still CCP. That CCP3 that's high, and especially if it's in the top 20%, is more likely to progress. And then the other, I think, single takeaway from that is there's a slight elevation in peripheral T helper cells. That the number, which is really, really low, goes up by like 2% or something. But the people who have higher T helper cells at baseline are more likely to progress. And the ones that do progress get more T helper cells in the peripheral T helper cells. And those two together have predictive value. But when you look at the AUCs, the added value of going from just looking clinical parameters, age, sex, CCP, you know, the AUC was like 0.65. And if you added on these cellular subset analyses, it was better, but the AUC went to like 0.72. So was it worth, you know, all the science? I think the science tells us about what's going on, because there are other reports here about peripheral T helper cells and some other T cell subsets that are present at baseline do predict progression. That's good. That tells us about what's going on in those people. But the clinical utility of that, it's still high index of suspicion and those autoantibodies, and you follow them. All right, folks, that's it for this day one recap from ACR25. I want to thank Orly, Janet, and Hughes for their great insights. Tune in tomorrow, same time, 5 p.m. Central, for the day 2 recap.